This is GU male, predominantly involving all of those things other than testosterone replacement. We'll kind of fly through these things and then we'll discuss testosterone in another talk. So just to remind you that urology is something different than renal. Urology involves the collecting system, basically from the pelvis of the kidney down. Renal involves the kidney function itself. So a nephrologist addresses renal issues, a urologist addresses drainage issues. So UTIs, lots of treatments for UTIs, lots of people get them. Women get them way more than men do because of their short urethra. Men should not be getting urinary tract infections unless they've had some kind of instrumentation, such as a Foley catheter. We do tolerate a little bit more later on in life just because men seem to hold their urine longer, to produce less urine, and therefore have a little bit more risk. But a young man, we're going to be thinking STI rather than urinary tract infection. This is why I don't have my medical assistant get urine testing on a man before I see them, but I always do on a woman, just because a woman is way more likely to have a UTI. A man, if they have urinary symptoms, is more likely to have an STI. So I have them wait. For an STI, you want a dirty urine, urine in which they don't clean themselves off. They can't have urinated for 1 to 2 hours, and they urinate the very first amount of the urine into the cup. This is then tested for gonorrhea and chlamydia. Urinary tract infection, they should have cleaned themselves off. They should have urinated a little bit, catch a midstream urine, and it doesn't matter how long it's been since they urinated. Although I do find that if people are urinating really frequently, they don't seem to build up quite as many white cells or nitrites. The most common causes of UTIs are E. coli and the so-called enteric bacteria. Obviously, more unusual bugs can happen in people that have been instrumented. Treatment options include various antibiotics. Check the Sanford guide for what's the drug of choice for certain bacteria. And we'll learn as we go through the program various things to look at. For most people, you can start with either Bactrim if the sensitivity patterns in the community are less than 20%, or you could use a quinolone, although those are have a major warning related to tendon issues. Nitrofurantoin is another good option. It's a twice a day for 5 days medicine if you use the macrobid, the sustained version of this. But there's a number of different options. In children and elderly, use of bugs that hit more gram-positives are more common. Nitrites are not formed if it's a gram-positive infection, so one would not use that if the patient was nitrite positive. But if they're nitrite negative and you do have evidence of a UTI, especially in children or the elderly, something like Keflex or something like that is a very reasonable option. Pyelonephritis means infection that has traveled up into the kidney, into the pyelo means that pelvis of the kidney, the collecting area. Usually these folks are sicker, they have fever, they have flank pain, they often have a little bit of blood in their urine, they may have some vomiting and diarrhea. Obviously, in these people, you're going to make sure that you do a longer treatment and usually a stronger treatment. So for most of these people, a quinolone twice a day for at least 7 days is a sort of a minimum treatment. Again, refer to the Sanford guide or Up to Date or some other resource if you have doubts. Urinary stones, we often refer to them as kidney stones, but the majority of stones are actually in the ureter. This is when they hurt, just because a stone that is in the pelvis of the kidney is moving around unimpeded, is not interfering with urine flow, and therefore does not usually cause pain or nausea. Stones that are traveling down the ureter, which is a sort of the size of an oversized piece of spaghetti with a lumen in it. Those stones often have spicules and things sticking off them, and will be cutting up that ureter as they go down and causing a lot of pain. The majority of urinary calculi are calcium. Some are pyruvate, some are uric acid, but the majority are calcium. Because of this, the majority, but not all, do show up on X-ray. So a KUB can helpful to see where a stone is, but it clearly does not rule out the possibility of a stone. One can use dietary interventions for urinary calculi, such as increasing lemon. Some evidence for this, although the amount that you need is probably more than the average person would get. So how do we treat stones? In most cases, we'll use trial of passage, give them pain medicine, have them increase their fluids and hope it passes. In some people, we think that alpha blockers are helpful because they will dilate that ureter. There's not a lot of strong evidence, but on the other hand, there's not a whole lot of downside. So many people will give them tamsulosin 0.4 milligrams once a day, usually at bedtime, to see if they can help that stone pass. The stone can be basketed if it's way down in the ureter in the lower third or so. They can actually go in through the bladder and put a basket up in there. They can also go through percutaneously to try to get it out. Lithotripsy breaks up the stone using sound waves, and in extreme cases you sometimes need to do surgery, almost always reserved just for what they call staghorn calculus, which has really basically just filled the pelvis of the kidney. They basically have to remove the kidney, cut it in half, remove the calculus, and then sew it back together and put it back. So to shift gears a little bit, overactive bladder. Now, overactive bladder is way more common in women than it is in men, but you do also see it in men. Up until recently, we really only had one option for treatment of overactive bladder, and that was anticholinergic medicines. Remembering, that the cholinergic system, the parasympathetic nervous system, causes bladder contraction, so anticholinergic relaxes the bladder. In many cases, this can result in urinary retention, but if we use a very selective, relatively low dose, we can actually get rid of the bladder spasm without causing urinary retention, but that is always a concern. Now, a beta-3 agonist also relaxes the bladder, does so without the systemic effects of an anticholinergic. Anticholinergics can't see, can't spit, can't pee, can't defecate, but the beta-3 agonists are very specific to the bladder. So the treatment options for anticholinergics include all of these. All of them seem to work about the same. Some seem to work better in some patients than others. Some of the older ones, such as the ditropan, are a bit less selective to the bladder and do seem to have more side effects. But basically, they are similar medicines. Myrbetriq is a beta-3 receptor agonist and, as noted, seems to have less side effects. Unfortunately, like so many medications that have advanced like this, it is substantially more expensive and often will require additional paperwork and sometimes prior authorizations. So again, if you use anticholinergic medications, to either do sleep or urinary incontinence, there is some evidence that seems to suggest the risk of developing cognitive impairment is increased. So sexually transmitted infections. GC and chlamydia are tested by urine. They usually cause symptoms in men with some dysuria. They usually are totally asymptomatic in women. Unfortunately for women, they can ascend up the tract and cause PID. pelvic inflammatory disease, and often, even if it's not to that extent, they will have damage to the fallopian tubes, resulting in infertility. HPV is a human papillomavirus. There is a vaccine for that now, the Gardasil 9, that has 9 strains of the HPV in it. These are the strains that seem to be associated with infection, not only in and of itself, but infection that results in cancer. So not only cervical cancer in women, but head and neck cancers in both men and women associated with oral sexual activity. So it is something that we are becoming more aware of. There is good evidence that the vaccine is effective, although the vaccine has really not been out long enough to be completely sure that it's effective, just because some of the folks that I see, men in their 50s that have HPV, tonsil and throat cancers, obviously had no chance to get the vaccine. So we'll see 20 or 30 years from now whether it's an effective vaccine for that. But there does seem to be some decrease in cervical cancers because women do seem to get those a bit younger than my panel of patients of men that get the head and neck cancers. HSV2, herpes virus 2, genital herpes. Clearly there are good treatments for this with valcyclovir, famciclovir. There is prevention of passing infection. Unfortunately, it is not curable. You can get herpes simplex on your genitals from herpes simplex 1 time, but the next time you'd get it, you would get it on your lips and other places where you would traditionally get it. HSV2 traditionally breaks out somewhere in the boxer shorts distribution, and then an antiviral is started. HIV is an infection which has good control, but again, no cure. Syphilis is increasing in Maine. We used to say it was mostly just with men who have sex with men. That is still the population that we see it the most in, but we are starting to see it in other populations, so we are starting to test for it more. Relatively easy to treat with penicillin, but you have to find it before you can treat it. Hepatitis B is another sexually transmitted infection. It is not curable, but it is pretty well treatable with things like Baraclude. Something that we need to be aware of. Most of the young folks have been immunized, as well as healthcare workers, but it is something that we need to keep in mind. Hepatitis C is pretty much curable now with Harvoni. It is something that has a number of different subtypes, not all of which are curable, but the majority are. So we're probably up in the 96-97% percentage that are curable. We need to be aware. We're supposed to screen anybody that was born 1965 and earlier with a single HCV test. On the other hand, anybody that has any sort of risk that's younger, I tend to test just because, as noted, it's curable now. And even though a percentage of people will fight off hepatitis C by themselves, they'll become immune after getting rid of the infection. But probably 60 to 70% of the time it goes chronic, and in those people it can damage the liver and result in liver cancer. So benign prostatic hyperplasia, BPH, a lot of people call this hypertrophy. It's not really hypertrophy. Hypertrophy is when the cells increase in size. Hyperplasia is when there's an increased number of the cells. So hyperplasia is the more technically correct term. 75% of men over 50 have at least some symptoms. They'll have a little bit more difficulty starting their stream. They'll have a sense of incomplete emptying. 30% eventually have surgery, but there are some medication approaches that we are using now that really seem to be putting a dent in that number. So just to remind you of the anatomy, the prostate is a gland about the size of a walnut. It basically is around the urethra, so the urethra flows directly through the prostate gland. The prostate gland is responsible for probably 70% of the seminal fluid. So when a man ejaculates, 70% of the fluid that he's ejaculating is actually prostate fluid. Less than 2 or 3% are actually sperm. This is why after a man has a vasectomy, there's no real substantial decrease in his ejaculate. The growth of the prostate gland can happen both on the outside, so the outside of that walnut, but also in the inside, what we call inside the surgical capsule. So when that happens, you'll have a increased resistance and therefore more likely issues of urinating. So what are those issues? Decreased force, they'll dribble a little bit after they urinate, they're getting up at night to urinate. One time is not considered nocturia. Anything more than twice a night is considered nocturia. These men will often have the sense that when their bladder is full, that it's really full and they really need to go. Some of them will have dysuria, although that does raise the specter of infection, and hematuria, of course, raises the specter of infection, as well as being a concern for bladder cancer, just because sort of painless hematuria in my book is bladder cancer until proven otherwise. So if you have somebody that has BPH, you need to make sure that it's not being the symptoms are not actually being caused by cancer. So what do you need to do? You need to do a digital rectal exam, feel the prostate gland through that anterior wall of the rectum. Should be smooth, should be an appropriate texture. Roughly, I find it's the texture of sort of cooked steak. If it's harder than that, that's inappropriate. If it's boggier than that, that's inappropriate. But you do need to get a sense of what the appropriate density of that tissue is. Urologists will often say a certain number of gram, 15 gram, 30 gram, and that really is based on the number of finger breadths of the prostate gland. So a 2 finger breadth prostate gland is actually a 30 gram prostate by research. And they will describe that even though they're not actually measuring the weight of the prostate gland. A PSA is a blood test which is elevated in both BPH, but in prostatic cancer even more. So if you have somebody who has difficulty urinating and you're thinking they might have BPH, you do a PSA. The normal for most men above 50 or so is less than 4. If you get a 5 or a 5.5, usually at that point you can wait 3 or 4 weeks, repeat it, and tell the man not to have any sexual activity for 4 or 5 days before, and oftentimes it will have returned to normal. If it's still elevated, then you're in the position that you may have to refer him for a biopsy. Biopsies are done transrectally. They basically punch out 16, 18 different cores of prostate tissue through the rectum. They send those off for analysis. When they analyze those, they basically determine how cancerous they look. So totally no cancer is a 0, and totally anaplastic is a 5. So just to remind you, cancer cells don't look anything like the original cells if they're totally anaplastic. The variation of how anaplastic they are is how differentiated they are. So normally a cancer cell is differentiated to the point where you can recognize it as a prostate cell. If it's very poorly differentiated, then obviously it comes with a more poor prognosis. So basically, you have this man, he's got BPH, you do a PSA. If it's under 4, that's an all clear, you start the medicine. If it's above 4, you repeat it. If it's repeated and it's still elevated, you're going to have to refer them for biopsy. Sometimes they ultrasound the prostate gland. I don't usually do this, but sometimes the urologist will. The USPSTF guidelines talk about not doing PSAs for screening, but in a person that has BPH, you will need to do it. Pharmacology treatment for BPH, there's 2 basic options. One is to relax the sphincters a little bit and decrease the outflow resistance. These will work within a day or 2. These are the alpha blockers, things like tamsulosin, also known as Flomax, but also the older ones of Minipress and Prazosin, Doxazosin. All of these are less selective to the alpha receptors. Basically, this is alpha-1 receptor that we're blocking, and tamsulosin actually blocks the alpha-1A, so it is less likely to have problems with orthostatic hypotension and similar types of issues. Now, if you want to go more long-term, you can actually block the conversion of testosterone from one type of testosterone to the other. This is an alpha-5 reductase blocker. And basically, by doing this, we decrease the stimulation of prostate growth, and eventually there will be decrease in the size of the prostate. It takes at least 6 weeks to even start working. Often takes several months before you'll see substantial effect. Also usually does increase hair growth, although that's pretty variable. Maybe half or less get increased hair growth. Erectile dysfunction, this is the inability to get and maintain an erection adequate for intercourse. Happens to at least 25% of men, 65 and older. Some estimates are even higher. 90% of those men have a physiologic basis to their erectile dysfunction. We used to think that 90% it was psychological, but now we know that the majority do have a physiologic basis. The usual approach to this is the PDE-5 medications like Viagra, Levitra, Cialis. These basically block receptors and result in dilatation of the blood flow to the penis and result in substantial improvement in those ED symptoms. Just as an aside, there are a percentage of people that you can't use these PDE-5 medicines on, most notably people who have nitrates. So if they're on nitroglycerin or isosorbide or something that's a nitrate, you cannot use these PDE-5 medicines just because you can get a profound hypotension. You do need to look at other alternatives. There's injectable medicines, there's urethral suppositories. In extreme cases, we do sometimes still do penile prostheses, but we don't do those very often anymore. Just to review a few miscellaneous issues, prostatitis, you're going to have them on antibiotics, usually substantially longer. Recommendations do vary, but most of us keep them on at least 2 weeks and often a month. This is a patient that comes in with sort of vague urinary symptoms, pelvic discomfort. I usually check a PSA. It's usually a little bit elevated, and then I start them on antibiotics, and then the PSA comes down. Unfortunately, some of these people also have prostate cancer, so you do need to track that PSA and make sure it does come down with infection, because if it doesn't come down, or in bad cases it'll actually even go up, then you need to refer them to a urologist to get a biopsy. A varicocele has no pharmacologic treatment. These are pretty common. Probably 1 in 6 men have a varicocele. Just need to be aware that it exists, and there really isn't any treatment for it. Testicular torsion, teenage boys come in with a lot of testicular pain. They have torsion until proven otherwise. They need an ultrasound. And basically, if that testicle is twisted, it needs to get untwisted to restore the blood flow. And unfortunately, a substantial percentage, 10-15%, will lose the testicle. So you do need to diagnose this and get those kids to surgery. That sort of summarizes the basics on some of these male health issues. Obviously, we'll continue to talk about these issues as we go through the program.